So now we are going to see the intraosseous IU access which you want for the doctors. Okay. Usually the doctors will be the one who will be asking for it, but you also can suggest, because according to the rule, first to try for the IV, you have to do 2 tries. And if you are not able to get an IV line, then you have to immediately inform the doctor that okay, we can go for an intraosseous. But usually doctors don't prefer that. Sometimes they will say okay, call the anesthesia or whatever it is, and then or central line or whatever you get. But the rule is that first 2 tries on your IV, and if you are not able to get an IV, the next step is intraosseous. That is the protocol from the AHA and okay. So the intraosseous that you have over here will have the drill and 3 types of needles. Okay, 3 sizes. The smallest one is the 15 mm needles, which in Kuwait is usually used for children. Okay, then you have the 25 mm needles, which sometimes mostly used for adults. Sometimes 15 also is used for some slim adult patients, and 25 used for obese children. Okay, and you have the 45 mm, which is usually given in the proximal humerus. Okay, now there are 3 different sites for giving your IU. Okay, you have your proximal humerus, and in your tibia you have your lower tibia and your upper tibia. Okay, so these are the 3 different types. These 2 needles are for your tibia, and this is for your proximal humerus. Okay, when you are giving your proximal humerus IU, you have to give it in a 45-degree angle. These 2 you have to give it in a 90-degree angle. Okay, that is the difference between these things which I told you. This is used in tibia, this is in proximal humerus, and this is in a 45-degree angle you have to give, and this one in a 90-degree angle. Okay, this all will be done by the doctors. You don't have to worry much. They are the ones who will be doing it. Okay. So, okay. Now regarding the position, for a proximal humerus, you always have to make sure that the patient's arm is kept above his abdomen, or his palm is twisted and kept outside, facing outside the body. The reason why we have to do that is to make sure your bicep tendon moves out of the way before giving the intraosseous. So either you keep your patient's arm like this, or you keep your patient's arm like this. Sometimes you have that electrical, automatic CPR machine. So when that is kept on your chest, sometimes you won't be able to keep the patient's arm like this. So at that time, you have to make sure that the patient's arm is kept like this. Okay, otherwise you can keep your patient's arm like this and then move the weapon, and then you can. Okay, so that is one position to give the proximal humerus. Now after you have kept the patient's arm like this, you can palpate this area, the shoulder, and with your palm, both the palms, you have to rub on the lateral side of this shoulder, and you will see that it's like a golf ball and tee, like a ball kept on a ball, and you will touch that position. Just 2 centimeters above that is the position to give the intraosseous. Okay, the doctors know about this position, so you won't have to worry much. They will take care of that part. Okay, that is for your proximal humerus. For your tibia, you have the most prominent area over here below your patella. Just 2 centimeters medial to that. That is your position for giving in tibia, in your upper tibia. And for your lower tibia, you see the medial malleolus, just 2 centimeters above the medial malleolus. That is the position for giving in the lower tibia. So these are the 3 locations that you can give your IO, 3 on this side and 3 on this side of the body. So for example, if you are not able to give on one side over here, you can switch on the other side. Which the doctors will do. They will switch to the other side if there is some issue with one side. So total you have 6 sides in one body. Okay. Now those are the positions to give the thing, and I told you the angle also in which it has to be given. Now let's come to the equipment. Okay. You will have the power driver. This power driver, if it is working fine, it will show a green light here. If it is not working fine, it will show a red light. This means that the battery is coming down and it is time to change it. Your intraosseous power driver is working fine, so the green light is there, which means it is working perfectly fine. Okay. Mine, since I've been doing a lot of demo, it has become red. Okay. Now your needle will come in one packet, one set. Okay. Inside this set, there will be many items which I've kept over here. The first one that you see over here is a card saying that you should not give it in the sternum. This is not for giving it in the sternum. Okay. All the other items I have kept here. I will explain to you in detail. You have the needle, the 25 mm or the 15 mm or the 45 mm needle will be inside the packet. You will have a connection set. Okay. You will have a stabilizer, a sticker, to make sure it's placed properly. You will have a wristband. This is a pink wristband. This is usually put after the intraosseous is placed on the patient. You put this on the wrist of the patient. This reason is because this is a metal device, and sometimes the patient will be taken to MRI or CT. And usually it is given in the tibia, blanket will be covered on the patient. So the technician in the MRI should know that he is having a intraosseous in his leg. So you always have to place this on the wrist of the patient after the intraosseous is given by the doctor. Then you have a safety device, sharpener for putting the sharp. Okay. Now the doctor will take the driver. He will first choose the position. It will be tibia or proximal humerus, depending on what the condition is. He will choose the position. He will take the driver. Now, for example, just think of this as a mannequin. Okay. This is magnetic, so you can connect it like this. It's magnetic. It stays there. Okay. Now hold the base of the needle and remove the cap. Okay. You can clean the area with your normal cleaning water, chlorine or something. Okay. And now the doctor is going to drill. First, he will insert the needle till it touches the bone. Now, as I said earlier, this is a tibia. This needle is for tibia, so he'll be inserting it over here or down. Okay. He will insert it till it touches the bone. The doctor should not drill before he inserts it. First, he has to insert and it has to touch the bone. Okay. When it touches the bone, you have to make sure at least one black line which is seen here in the needle should be seen above the skin. Okay, at least one black line. All these needles have a black line. You can see one black line is there. So all these needles have a black line. So you have to make sure that at least one black line is seen above the skin. So when he inserts, it goes inside and it touches. If it is touching like this, if it has touched the bone and still the black line is not seen, this means that this needle is not the correct needle. There is no space to drill down. So at least one black line should be seen above the skin when the doctor inserts the needle. Okay. So I am taking this, I am inserting, and probably now it has touched the bone. Okay. I have not drilled, which means that if it goes like this and I have not drilled, means that I can change the needle. I can choose a bigger needle or I can choose a smaller needle, whatever the doctor. So I have inserted and it goes inside. And it's like this. It has touched, and I can see at least one black line is seen above the skin, which means this is the correct needle. Okay. Now the doctor has to drill. So first insert before drilling to make sure that this is the right size of the needle that you have to. And then I drill. It goes inside. When it goes inside, you will feel that the doctor will feel that the resistance has reduced. That indicates that the needle has crossed that cortical hard part of the bone, and it has gone inside to that bone marrow. It has reached that bone marrow. So that resistance will be gone. So that the doctor will feel when he is drilling. He will feel that the resistance has gone, which means the needle has passed through the cortical bone and reached the bone marrow. Once that happens, he will remove the driver. Okay? And then he will move this cannula. He will put it inside this. Okay? Now, you will have to, as a nurse, you will have to take this and put it like this. Okay? Don't pull the sticker now, just wait. And then take the connector, remove this top edge, and then connect it. And then you have to already keep a normal saline which is prepped ready to do a flush. Okay? If the doctor wants, he can aspirate. Okay? Just that a little blood will come out. There will be a pushback of blood, that is normal. Okay? And then with that normal saline you can push so that the bone marrow moves and you have enough space for giving your medications. All the medications that you give through an IV can be given through intraosseous. Okay? And then you remove and you connect your IV or whatever it is. After it is perfectly done, then only you remove the sticker and place it properly. Okay? So this is how you have to give an intro. So your work is, after the drilling is done, for putting the stabilizer and everything is your particular work. According to Kuwait's protocol, nurses are not allowed to drill. Only the doctor is allowed to drill. Okay? And you can keep this. Our company says you can keep up to 72 hours, but in Kuwait, only 24 hours you are supposed to keep an IU intraosseous. After that, you have to remove. Okay? For removing, you will remove your IV connection set, whatever is coming. You will remove like this. one, we'll remove. We'll pull out the sticker, take it out, and a lure lock syringe. With any lure lock syringe, just connect and twist it clockwise. Come out. Okay. Try to do the twisting in one motion because the patient will feel the pain when it is happening. While you are giving the intraosseous, the patient might be unconscious, so pain won't be a problem. But while removing, his conscious would have come, and so the doctor should remove it as quickly as possible. This also Dr. Oli will be doing. They know about this. So your portion is very little in this. Now, after that, you can just put a normal bandage or anything, whatever. So this is your thing for intraosseous.
Thank you.